главному врачу нашего центра доктору медицинских наук, профессору Суфьянову Альберту Акрамовичу.
Okay, there's Albert in front. It looks like they're getting ready there. It looks like Dr. Short. There we go. We'll let Albert speak.
Дорогие коллеги, позвольте вас поприветствовать в этом зале опять. Я очень рад всех вас здесь видеть. Я увижу уже знакомые лица, которые находятся здесь уже регулярно. Вот, наши друзья, практически уже одна семья. Вот. Поприветствовать наших лекторов, профессора Шредера, нашего старого друга. И сегодня у нас в аудитории новый лектор из Индии, профессор Шикар, вот, Чандра Шикар, yeah? So it's a very big honor and pleasure for us to see our old friends here. Я надеюсь, что у нас все будет плодотворно, все как всегда. Я очень рад, что курс стал уже на регулярной основе, это очень важно, что практически все во всем мире знают, что октябрь, ноябрь у нас идут два курса, это Skull Base и эндонатальный курс. Вот, и это стало доброй традицией. И хочется это поблагодарить, конечно, администрацию Тюменской области, которая дает нам возможность это проводить, потому что, вы сами понимаете, мероприятие очень дорогостоящее. Вот, требует, конечно, и материальных, и таких денежных вложений для того, чтобы все было приведено на уровень. Тем не менее, до настоящего времени все пока у нас получается. Я надеюсь, что это будет продолжаться и в будущем. Почему? Потому что такие именно мастер-классы, я считаю, они очень важны для образования и для формирования будущей российской и международной нейрохирургической элиты. Вот, потому что, понятное дело, значит, пообщаться на съезде, пообщаться, значит, просто послушать какие-то лекции. Другое дело своими руками на анатомическом препарате сделать доступ. И не только сделать доступ, но и сделать это под контролем опытного коллеги, который имеет колоссальный опыт в этом разделе, является лидером. Вот, поэтому вот такие лидеры присутствуют сегодня с нами. Вот, я понимаю, что все очень заняты, поэтому низкий поклон нашим профессорам, профессору Шредеру, профессору Чандре Шикару, за то, что они все-таки вырвались из своего плотного графика. Вот поверьте, я вот знаю, что, например, профессор Шредер прилетел сюда прямо из Китая, пролетом прямо вырвал буквально 2-3 дня из своего графика. Вот, поэтому низкий поклон нашим лекторам. Я надеюсь, что все у нас получится. Давайте мы откроем наш съезд и предоставим слово профессору Шредеру.
Первая лекция «Эндонатальная анатомия». Самые приветственные слова еще, извините.
Уважаемые господа, доброе утро. Я очень рад, что я у вас в гостях. Большое спасибо за приглашение. Я говорю по-русски очень плохо, но я надо говорить по-английски. So, I'm very happy to be here. I know Albert for many years now, and I'm very happy that we have this very close relation and collaboration. And I'm very impressed because I saw how he started in Irkutsk with a very small department, and now he's running the most busy department in Russia, and that is very good. And I really appreciate that he always try to keep pace with the top of medical developments to cover all the fields in his department. It is endoscopy, cerebrovascular, and brain surgery, brain tumor surgery, everything. And I really congratulate for your achievements. And we want to make this course very informal. So it should not be just frontal lectures, but you should ask questions immediately if you have, so that you really have a good educational event. We want to show you about endonasal skull-base surgery, what can be done, what is the limits, when we have to be careful. And I think we have also some live surgeries, but the main focus should be cadaver hands-on dissection for you, that you get some experience how to do it, how it's looking like. Is this okay? Who has already experience with endoscopy? Nobody? And what kind of surgery? Is it skull base or intraventricular? Skull base, we have already. But many of you have not. So then we should start from the beginning, I guess.
Yeah.
I'm very happy that we have in our faculty Professor Jibujari from Mumbai. He came here to help in teaching. Professor Veit Rode from Germany, he could not come because of a problem in the family. And we have Roman from Slovenia.
Роман Босняк, yeah. Он не приехал еще?
He will come a little bit later. Yeah.
Роман come now.
Okay. Grigori. We have ENT support, which is very important. And you start with nasal surgery. It really makes sense that you have somebody from the ENT guys who is helping you with the preparation of the nose, because you can learn a lot how to treat mucosa, how to treat the sinuses. In some departments, there's a lot of struggle between ENT and neurosurgery, and then of course it's difficult to establish it. But if possible, it's very good to have a good collaboration. All right.
All right. We also start with ENT in this center.
Yeah.
First ENT when we start.
So we
alone.
should start now.
A little bit. Some words about.
Professor Chandrasekhar.
This is a new member of our team. So this is very famous neurosurgeon from India, from Mumbai, with a lot of experience in this, not only in skull base, but also in pediatric, pharyngioma, and so on, vascular. So please.
Thanks, Dr. Sufiano. Must thank for this opportunity to visit your center, and whatever I saw yesterday has really been very impressive. I hope to contribute from our experience on some of the endonasal aspects. I think the importance of ENT surgeon, unfortunately my colleague could not come, but I think is extremely important for understanding the endoscopy of the skull base, because you are learning the anatomy all over again of the same region that you are familiar to operate intracranially. You need to get equally familiar and this is the main, I think, purpose of this course, as Henry has. So look forward to next 2 days of interaction, and I hope it is more of an interaction than just a lecture. So thank you.
Thank you. Thank you. Так, ну, мы, наверное, сейчас начнем, да, уже такую практическую более часть. Поэтому еще раз подчеркиваю, в этом году мы решили поменять формат, потому что мы постоянно ищем формы, как сделать мастер-класс более лучшим. Вот, если раньше это был один курс, искал бы и эндоназальный в одном, в этот раз решили попробовать все-таки отдельно сделать, чтобы люди получили больше навыков и больше общались с инструкторами, с опытными, в режиме онлайн, скажем так, в индивидуальном порядке. Поэтому в этом году решили сделать отдельно. Посмотрим, как получится. Если не понравится, вернемся к старой форме, я так думаю. Но попытаемся, посмотрим, что получится в этот раз. Поэтому первую лекцию мы будем слушать профессора Шрёдера. Henry, please.
So the first lecture is a little bit about endoscopic anatomy. It's not a detailed report like the anatomist is giving it to you, but it's just from the clinical aspects. What is really necessary if you make a standard approach to the stellar area. So we don't have all approaches which are possible in the nose. Maybe you can hear it from the ENT side more extensively. I just want to give you the endoscopic anatomy of the midline skull base, what we have as a neurosurgeon. And why are we using the endoscope in endonasal surgery? And maybe everybody of you has started with microsurgical approaches to the sellar area. And then you know when you take a speculum inside, you lose a lot of illumination, a lot of light already at the entrance into the surgical field. You have only a little bit illumination here in the depths. And because of the microscope, you have only a very small field of view. And this is sometimes difficult with orientation. When you bring the endoscope in, you have this wide angle of view. Because of wide angle optics, you have a good orientation because you see all structures which are lateral to your approach. You have perfect illumination. And this is a big advantage. So the endoscope is always better than the microscope if you have a deep, narrow surgical corridor. So this is a view we have when we use the microscope. You see, this is a margin of the speculum. This side and this side, and this is the sellar area. Here's a little bit of clivus, but you see basically just the sellar floor. And now we take the speculum out and bring a 0-degree endoscope in. It's the same patient. And then you see that. See the difference. This was the aspect we had with the microscope, but now you see the clavicular on the right side, on the left side, optic nerve left, optic nerve right. Clinoidal segment of the carotid. Here's the cavernous segment. Lateral optocarotid recess. Medial optocarotid recess. So you see everything very nicely with this endoscope. Before you start your surgery, you should have a good imaging. That is very important for your orientation. It's much more valuable than navigation, for example. So we have to make imaging. And what we do is a CT. And in the CT and the axial view, you can see what is the size of the sphenoid sinus, for example. Where do the septi go? Frequently, the septi go to one of the carotids. Only in a few cases, it's really in the midline. You can look what is the structure of the ethmoidal cells. And very important, what is about the septum, the nasal septum? Is this midline? Is this a deviation? Sometimes you have a bony spur going to one side or the other. So it's very important to plan your surgery. And also it's very important that you look that really the bone is covering all the structures. Sometimes you see there's a bony defect over the carotid, very thin. And then if you do not take care, go in with your Blakesley or so on, you can easily damage a carotid. And this is what sometimes happens when the ENT doctors make a sinus surgery. When you not take care, you can injure the carotid and this can be a disaster. So the anatomical landmarks in the CT, the bony landmarks are very important to be considered before you start with the surgery. So, and of course, in the sagittal plane, again, we look what is the pneumatization of the sphenoid sinus. Sometimes the sphenoid sinus is very pneumatized, then it's very easy for you to get access. But sometimes you have a conchoid type and it's all is bone. And you should know this before. This is very important. And again, also, what is the bony covering? Is there any defect to the skull base? Coronal view, you look to also to the sphenoid sinus. You see this is a bony canal. It's for the median nerve, pterygoid canal. Very important, it's a major landmark for you. You see the septa, how many septa are inside. It's just 1, 1, 2. What is about the lateral recess of the sphenoid sinus? All these anatomical structures can be easily seen on a CT scan, so you know before what you can expect. And here we look for the septum. You see a little bit deviation, but not much. Here it looks very good. You see what is the size of the turbinates. Sometimes they're very large. It's called concha bullosa. Then you have to resect to get space. Again, we look here what is about the septum in the sphenoid sinus. So the CT scan is very important for your planning of the approach to know what you will see during the surgery. Then, of course, you have MR imaging, especially if you have lesions which are intradurally. If we have just a pituitary tumor, what we want to see how is the degree of the invasion of the cavernous sinus. You see, this is only displacing the cavernous sinus, but sometimes the tumor goes around the carotid. We want to look where is the pituitary stalk. You see, the stalk is usually a very bright signal. In most of these large tumors, it's pushed upwards and backwards. You see, like here, this is the stalk. And this should be known as well. If you have other lesions, we want to look what is the extension intradurally. Is there an engagement of the carotid? All of these are important information. So imaging is very important before you start. And how is the development of the pituitary gland? You know, there are two parts of the gland, two major parts. There's the anterior lobe of the pituitary gland, which is producing most of the hormones, and we have the neural part of the pituitary gland, the posterior lobe, which is producing only a few hormones for the water regulation, and oxytocin also important for several processes in the body, not only during the lactation period. So it's very important. Also, you see there is a so-called Radke pouch, which comes from the roof of the nasopharynx. And this is origin of the adenohypophysis. And you know, sometimes there are remnants of this Radke's pouch, which creates Radke cyst, which can bring some problems for the patient and need surgery, and sometimes it's the origin of craniopharyngiomas. So the cellar type is very important for our approach if you want to go to the cellar area. This is an ideal case. It's very well pneumatized. The air is in front of the cellar and at the bottom. Sometimes you have a smaller sphenoid sinus, a pre-cellar type, so the air-filled cavity is just in front of the cellar area. This is not too bad, can also be have an easy approach to the cellar. But sometimes you have a conchoid type. There's only a very small sphenoid sinus, sometimes even completely absent. And then, of course, it's sometimes difficult to go through the thick bone and to find the cellar dura. And then navigation is very helpful to guide you. Here again is a depiction of the septi. Sometimes they are midline, sometimes they are laterally, sometimes you point to one of the carotid or the others. So it's very important that you look before you start the CT scan, and then you have a good orientation during the surgery. It's much more valuable than to use navigation. The carotid artery is one of the major structures in the field which should be preserved. It's very important that you look what is the course, because sometimes it is not a normal course. Sometimes you see the carotid makes a loop inside, goes very close together. Sometimes you have the siphon in an abnormal location. So it's very important that you look what is the course of the carotid. And sometimes you have a variation. That means a fetal type of the trigeminal artery is remaining, and this can run through this cellar space. And then you must be very careful, otherwise you will get a severe hemorrhage. To look to the carotid, very important. You see here is a depiction of the branches which comes from the carotid. Very important to preserve ophthalmic artery. The ophthalmic artery is running with the optic nerve through the optic canal. Then what is very, very important and frequently not considered much because they are very tiny vessels are the branches of the superior hypophyseal artery. They supply the chiasm and the upper part of the infundibulum. And if you have a craniopharyngioma or a tuberculum cellular, it's very important that you preserve these small branches. And then you have here the distodural ring. So this means in front is the clinoidal part of the carotid. Then you have the intercavernous part of the carotid. Then down you have the clival part of the carotid, and then the petrous part of the carotid. See again, here is a distal dural ring. This is a clinoidal part of the carotid. This is a cavernous part of the carotid. So you see a variation. This was an echomagnetic patient, and you see there's a kissing carotid. It's a very narrow. Then, of course, navigation is helpful, especially if it's a conchoid type, to avoid damage to the carotid arteries when you get access to this tumor. Here again, you see a sagittal view through the cellar area. You see this is a chiasm, pituitary stalk, anterior lobe, and here the posterior lobe. And here see the relation. This is a septum, nasum septum, sphenoid sinus. The septum is midline. This is good. You see the carotid is coming here, but it's coming here. But it's very variable, the anatomy. This is very variable, and you should make an individualized approach according to the MR imaging and CT scans. The cavernous sinus can be involved in some of the tumors. Usually nowadays we do not make surgery very much in the cavernous sinus as long as there is not a tumor extension going in. So when you have a pituitary tumor and this tumor is infiltrating the cavernous sinus, it can displace everything far laterally. And if you have a soft tumor, you can really get a total resection with the help of an endoscope if the tumor goes to the cavernous sinus. But otherwise, of course, there's no many indications to open the cavernous sinus to get access somewhere, because you have the nerves inside the lateral wall of the cavernous sinus. You have the abducens nerve, is the only nerve which runs through the cavernous sinus. And of course, there's a risk to damage these nerves. But if there's a tumor infiltration going around, displacing everything, then you can have a nice resection. Problem is, if the tumor is very fibrous, then of course it can be risky if you try to get a total resection. Here again, you see a view, cavernous sinus area. This is a carotid abducens nerve, and the other nerves are running in the lateral wall. Oculomotor nerve, trochlear nerve, V1, V2. They are only in the wall of the cavernous sinus. This was a dissection we just made a few days ago in China. This is a carotid artery. It's the cavernous part of the carotid. Here's the clavicle part of the carotid. And you see here, this nerve runs free through the cavernous sinus. This is the abducens nerve. Frequently, you see a branch from the carotid sympathetic plexus joining the abducens nerve when it travels to the supraorbital fissure. And up here, you see this is the oculomotor nerve. Another image is the carotid. That's on the right side. So the carotid is displaced medially. This is the lateral wall of the cavernous sinus. You see this is the oculomotor nerve coming from the interpeduncular cistern, going into the supraorbital fissure. The small one here, this is the trochlear nerve, and this nerve which runs free through the cavernous sinus. This is the abducens nerve. So when you start with your surgery, you go into the nose, you make your preparation. But the first thing what you see is a septum. This is the right side, the right nostril. You see this is a septum. This is the middle turbinate. And you see there's only very limited space. And initially, if you see this, you think, oh, it's very difficult without the speculum to get access. But if you take your time and you put epinephrine, so cottonoids in, wait a little bit, then you displace these structures laterally with a dissector. If you want to make an extended approach and the middle turbinate is very big, you can also make a resection. But we did also extensive exposure approaches, and we preserved the turbinate. So as much structures you can preserve, the better it is. The major landmark for me in the endonasal approach is the choana, because the choana is a fixed landmark. It doesn't matter what happened to the turbinates, you will always find it, and this gives you a very stable orientation. So if you are lost, you go down. So the most frequent mistake I see when we have courses about endonasal approaches, that the people go too far up to the skull base. They stay not down. Then you go back, look, where is the choana? You see this is Eustachian tube. Go just 1.5 centimeter up and you will find the ostium of the sphenoid sinus, the area where you want to go in most of the cases. So choana, very important landmark. Then we are looking always for the ostium to the sphenoid sinus. So you displace the lower turbinate, you displace the middle turbinate, and then you displace the superior turbinate laterally. And then you will find the sphenoethmoid recess. And in the sphenoethmoid recess, you see the ostium of the sphenoid sinus. Sometimes there's not a big ostium because it's hidden behind a duplication of the mucosa. But then you take a suction, you feel it, and you can enter the sphenoid sinus. Again, you see here, this is superior turbinate, this is sphenoethmoid recess here. Then we open the mucosa, we resect the mucosa. What you see then is a rostrum. You see one ostium on the left side, another ostium on the right side. If you see this keel of the boat, then you know you are in the right place. And this should all be removed if you want to get the access to the sphenoid sinus. And then you look into the sinus and you see there is a different septi. It's very important. Then you have the CT and you can make a correlation. And you know there's a lateral septi, a middle septi, another septa. You see an optic nerve coming here. This should be a lateral OCR. So it's depending from the pneumatization what you can expect to see. Sometimes you see it very well. Sometimes if the pneumatization is not too good, you don't see so much. Again, you see the beginning of the opening of the sphenoid sinus. You see the cellar floor in this area. This is the clivus, and you see the clival carotid coming up here. It's another view with a 30-degree endoscope looking more laterally. You see the optic nerve running here. This is a carotid, clinoidal carotid. Then the distal ring is coming, cavernous carotid, and down here is the clival carotid. Lateral OCR, optic nerve. Another view, a little bit more away from the beginning. This is a septum. You see the septum can be very much on one side. So you have a huge sphenoid sinus, and you think this is already all what you should expose, but there's another small sphenoid sinus on the other side, and there's a septum which should also be removed to get access to the other side of the sphenoid sinus. It's very important really that you look very carefully to the CT scan. Another patient, cellar floor, clivus, and this is the bottom of the sphenoid sinus, and down here is the choana. We look laterally again, optic nerve, lateral OCR, carotid artery, cellar here. This is the planum sphenoidale. On the other side, optic nerve, lateral OCR. This is the carotid here. If you have a very good pneumatization, like in this patient, you can even see V2. This is the optic nerve, lateral OCR, and here you see this is a V2. And down here you see the Vidian nerve. So it depends really from the pneumatization of your sphenoid sinus that you have all these landmarks. If you have a smaller sinus, of course, you don't see it. Again, here V2, and here's the Vidian nerve. The Vidian nerve is important because it's the landmark if you want to find the junction of the clival to the petrous carotid. You can follow the Vidian nerve, and this guides you exactly to this point. Again, you see an anomaly. This is the optic nerve, and you see it's running free through the posterior ethmoid cells, the so-called Onodi cell. And of course, you have to be very careful if you take a kerosene to open up that you not inadvertently damage your optic nerve because it's running free through the ethmoid cells. Sometimes it can be really completely surrounded by air cells. Again, optic nerve, and you see this Onodi cell here. So this is what we want to see in an ideal patient. Optic nerve on the right side, left side. This is the planum tuberculum cellae medial OCR, lateral OCR, glenoidal carotid. Here's a clavicle-carotid clivus. When we open the dura in a transtuberculum transplanum approach, the first thing what we see is the pituitary gland. Then we open the diaphragma celli, which is here, and we see the pituitary stalk. Especially in the craniopharyngiomas, it's very nice that you have an immediate orientation where is the stalk. When you come from a transcranial approach, you see the stalk in the last steps of the resection. Another important structure, what I mentioned already, is here's a superior hypophyseal artery coming from the medial part of the carotid and gives some fibers to the chiasm and also some branches to the chiasm and some branches to the upper part of the infundibulum on the other side as well. And these arteries can be very variable in the number and especially also in the size. So sometimes you have one major artery supplying it, and sometimes you have 1, 2, 3, 4, 5. Then after resection of a craniopharyngioma, you see here, this is what? Third nerve, so oculomotor nerve, exactly. One side and the other side, you see the basilar artery, superior cerebellar artery, P1 segment running here. Yes. So another image of the craniopharyngoma patient. You see displacement of the stalk to one side, superior hypophyseal artery, chiasm. This is a patient where you see the stalk is almost destroyed. Only some fibers here, small fibers here. This patient came with an Addison crisis. So you know from the beginning this stalk is not working anymore, so it's no problem, you just sacrifice it. Which artery is that one? Any idea? Louder? No, the ophthalmic is more in front. This is PCOM. PCOM running from the carotid back to the posterior cerebral artery. And here's again superior hypophyseal artery supplying the chiasm. This is a view into the third ventricle. If you resect the tumor from the third ventricle, you see foramina of Monroe, you see the course of the fornix. This is a roof of third ventricle. This is the mesa intermedia. We look more backwards. This is a mesa intermedia. You see this is a roof of the third ventricle, coral plexus. You see internal cerebral veins are above. This is habenular commissure, pinal recess, posterior commissure, and entrance into the aqueduct. Another patient sees the basilar bifurcation, P1, SCA, SCA, basilar trunk. You see the oculomotor nerve running here, coming between P1 and superior cerebellar artery. Another patient who had endodermal cyst here, sees pituitary stalks, pituitary gland, superior hypophyseal artery. One branch. Now we go in with the endoscope. In this area, you see very nice basilar bifurcation. Duplication of the SCA on one side, frequent finding, SCA on the left side, left oculomotor nerve, right oculomotor nerve, and you see here again small branches, perforators, important, mammillary bodies, both sides, and here's the floor of the third ventricle where you make your third ventricle ostomy.
Уважаемые коллеги, значит, на кафедре хирургии проводится мастер-класс, в рамках чего организована прямая трансляция на сайте.
An opening done for a chordoma and a clivus. You see clavicle carotid on the right side. There's a dura, there's a brainstem. Clavicle carotid on the left side. Stellar area, cavernous carotid on one side, on the other side. In this space, you see the pontine area. This is a tentorium, and this is a trochlear nerve running under the tentorium. Further down, you see trigeminal nerve. So if you have space, you can go in and you can really expose the prepontine area and the cisterns, CPA cisterns. So anterior and posterior lobe should be differentiated. This is a patient where we did a surgery for pituitary adenoma. You see this yellow thing with these structures, with the vascular structures. This is clearly the anterior lobe. It's a little bit yellow. And you see here the blood vessels. And here, when we open this layer of connective tissue, you see white tissue. This looks a little bit similar to the adenoma, but it's not. You should not mistake it as a residual of adenoma, but this is a posterior lobe. It has a different color. You see it's more white. It's very important that you differentiate between tumor and the posterior lobe. When we do the surgery, we try to make an extracapsular dissection if possible. And you see how important it is to have a good resolution camera. You see, this is a diaphragma celli. This small, very small layer of tissue, this is the gland. And you see again, it's yellow, and you see this vasculature. And because of the high magnification of the endoscope, it's really nice to see. With the older camera, sometimes we had problem to differentiate between this tissue and the tumor, but now with HD is no problem. You see, this patient has a good pseudocapsule, and we can really dissect the tumor around the pseudocapsule. It's not always possible, because if it's very fragile, you cannot do it, and you have simply to suck it. But if you have this plane, you can easily follow it, and you can really make sure that you have a total resection. So diaphragma, then we have the gland. It's very important that you not go too far outside. Some people say to make an extracapsular dissection, and then they go simply between the dura and the intracellular tissue, and then you are outside the gland. If you continue with this dissection, all the gland is gone. So you must preserve the small layer. It's a very small layer of pituitary tissue. You see, it's a very thin layer, but this is a gland. It's the remaining gland. This is a view in a child with a suprasellar arachnoid cyst. But it is very nice to show you the anatomy in this area and to show that the pituitary gland is swimming in a lagoon of venous blood. So that's why I think if you make a pituitary transposition, how it was originally described, that you simply take the pituitary gland out from the dura, bring it up and bring it back again, will not work, because the outflow of the gland is completely destroyed. You see, this is a lagoon of venous blood. All is sinus with blood. This is the infundibulum. This is adenohypophysis, and this white thing is a neurohypophysis. You see the carotid coming here? This is the ophthalmic artery. And you see here, these branches, 1, 2, 3, 4, 5, these are branches of the superior hypophyseal artery complex. Sometimes just one vessel, but here you see multiple. And they all supply the chiasm, and here this branch, the infundibulum. So it's very important that these are preserved. So, and again, you see the PCOM running here. This is an infundibulum, this is a stalk. Here you see the tuberculum cellae. So now we rotate the endoscope just around to have a look around. Carotid, ophthalmic. Here you see the PCOM. Small perforators coming from the PCOM, also very important. Yeah. It's only because it's a cyst. It is a cyst of otherwise you cannot have this view, but in a suprasellar area you have a really nice view to look around, and we only turn a 45-degree endoscope like a radar around, so we don't tilt the endoscope, so there's no additional damage what you have, it's just that we rotate it. Okay, so suprasellar anatomy, very important. This was after resection of an meningioma, and you see how much you have image quality with HD camera. You see, this is optic nerve on the right side. Here was the tumor. This is a carotid. What is this? What is this? Yes, this is superior hypophyseal artery coming from the medial wall of the cover of the carotid and supplying the chiasm here, branches, and the upper part of the infundibulum. It's very important that we try to preserve these vessels. See, this is ACOM here. This is the A1. This is a recurrent artery of Hübner. This is again the stalk. Here down is a gland. This is the carotid. You see, this is ophthalmic artery. Usually, ophthalmic artery is running under the optic nerve. And you must be careful if you resect the tuberculum meningioma that you preserve this vessel. So this was shortly a little bit anatomy, what we have, what we need to know as a neurosurgeon. Any questions? Вопросы есть? Понял? Да? Okay.
Thank you very much. Thank you. Excellent image. Дорогие участники, общайтесь. И то, что редкая уникальная возможность. Это, понимаете, не такой неофициальный формат. Он больше приближен к неофициальному. Поэтому выясняйте все вопросы, все нюансы. Такой возможности, но она будет очень редко предоставляться. Договорились? Не бойтесь. Вот в этом и смысл этого нового формата. Мы сделали его поменьше, потому что вы могли больше общаться и больше получить информацию. Okay? The people must not afraid to ask you.
No.
Yeah.
This is an interactive course.
Yeah, interactive. Small one, but more effective.
Yeah.
More effective, must be more effective. And also, again, Professor Schroeder, for giving us so interesting information and sharing your tips very deeply. Thank you very much. Thank you. It's really friend relation. Thank you very much again. Next is the speaker Григорий Полев. Это не по программе, but it's a very interesting ENT guy from Moscow, also our old friend, and I think his lecture is very hopeful. One more. I need more. And then I'm.
Доброе утро, уважаемые коллеги. Позвольте добавить немножко к прекрасной лекции профессора Шредера об анатомии околоносных пазух переднего основания черепа с точки зрения нейрохирурга. Основой, конечно, анатомии трансназальной является анатомия решетчатой кости. На протяжении нескольких столетий это было сложным вопросом. Харрис Машер в начале 20 века указал на то, что самый простой способ убить пациента – это выполнить эндоназальную этмоидоктомию. Вообще вопрос функции и необходимости околоносных пазух обсуждался с Средневековья, и очень долгое время пазухи считались резервуаром жидкости для охлаждения мозга. Сейчас расширяется знание физиологии пазух и их фундаментальной роли в функционировании слизистой оболочки полости носа и их функциях. Но мы подробно поговорим о доступах. Ведь что такое для нейрохирурга пазухи? Это элемент доступа к различным отделам основания черепа. Как мы знаем, из классификации Питтсбургской группы есть несколько модулей, так называемых парамедианных коридоров. Последней линии это трансфронтальный, транскрибиформный, транспланум, транстуберкулум, трансклайвал через скат доступ и трансодонтоид через зубовидный отросток. Таким образом, это, как я уже сказал, это доступ. Как говорил Алдо Стам, один из пионеров хирургии основания черепа, доступ является очень важной частью хирургии. Как мы видим, иногда этмоидоктомию даже необходимо выполнить просто для того, чтобы удобно разместить в полости носа эндоскоп и инструмент. Одним из проповедников этого был профессор Рикардо Карау, другой пионер хирургии основания черепа. Немножко поговорим об анатомии решетчатой кости. Как я сказал, это центральное звено и наиболее трудная пазуха. Ее анатомия наиболее вариабельна и вызывает много вопросов всегда. Для того, чтобы ее представить проще, нужно представить себе эмбриогенез и понять, что все пазухи, и решетчатая в том числе, это всего лишь пневматизация полости носа в латеральную стенку. И таким образом, все, что мы видим, весь сложный рельеф – это последствия инвагинации, последствия пневматизации в латеральную стенку. Это можно представить как несколько дверей, так называемых ламел, что очень хорошо описано в книге Левина. Мы можем представить себе анатомию решетчатой кости как несколько последовательных, чтобы скрыть решетчатую пазуху, нужно просто открыть несколько дверей. Это решетчатый отросток, это ламела решетчатой булы, ламела средней носовой раковины или основная пластинка средней носовой раковины, основная пластинка верхней раковины и передняя стенка клиновидной пазухи. Сейчас мы увидим, что на самом деле это достаточно просто. Первая ламела – это крючковидный отросток, как я уже сказал. На аксиальных срезах мы можем увидеть и узнать по его месту прикрепления к слезной кости. Здесь мы видим сослезные протоки. На коронарных срезах, пролистывая коронарные томограммы, мы можем увидеть его наиболее кпереди. Существует несколько вариантов прикрепления крючковидного отростка. Может появляться глазница, это наиболее частый вариант к основанию черепа или к средней носовой раковине, или даже иногда смешанный тип бывает прикрепление. Это больше важно для хирургии лобной или верхнечелюстной пазухи. Другие варианты прикрепления крючковидного отростка. И первая клетка решетчатой кости, которую мы видим, просматривая коронарные срезы, это клетки агерназии или клетка валика носа. Клетка валика носа или клетка агерназии является ключом хирургии лобной пазухи, о чем мы подробно останавливаться не будем. Удаление крючковидного отростка, если вдруг вы будете выполнять эту процедуру самостоятельно, не включает в себя ничего сложного. Единственное, о чем нужно помнить, это близость, как мы уже говорили, крючковидный отросток прикрепляется к слезной кости, и нужно просто не травмировать глазницу. Левая половина полости носа, кадаверный препарат, средняя раковина, здесь глазничная стенка, отсеченный крючковидный отросток и решетчатая була, и мы видим уже дополнительное соустье левой верхнечелюстной пазухи. И если продвинуться чуть глубже, естественное соустье верхнечелюстной пазухи и решетчатую булу. Таким образом, первую дверь мы открыли, и мы переходим ко второй. Это вскрытие решетчатой булы. В большинстве случаев после тщательного удаления верхней части крючковидного отростка уже видно соустье лобной пазухи. Но об этом, как я сказал, мы не будем подробно останавливаться. Различные варианты пневматизации клетки валика носа или агерназии, что имеет значение для поиска соустья лобной пазухи. И наша следующая ламела, наша следующая дверь – это передняя стенка решетчатой булы. Мы всегда ее, как вы видите, можем узнать после удаления крючковидного отростка. Это такая самостоятельная ячейка. и удаляя ее переднюю стенку, мы часто видим в ее верхних отделах переднюю решетчатую артерию. Об этом также необходимо ее положение выяснить до операции по компьютерным томограммам. Рассматривая снимки, мы можем узнать переднюю решетчатую артерию по ее месту выхода из глазницы между медиальным ректусом и верхней косой мышцей глаза. Существуют различные варианты ее расположения относительно переднего основания черепа. В данном случае мы видим, как она висит самостоятельно ниже основания и таким образом подвержена ранению. При ее ранении неосторожном может произойти ретракция в глазницу, что может повлечь за собой развитие ретробульбарной гематомы и необходимости наружной декомпрессии глазницы. Мы видим различные варианты положения. Другой вариант положения передних решетчатых артерий, более безопасный, в толще кости переднего основания черепа. Также мы видим, что артерию легко узнать по такому конусовидному вытяжению и верхней косой и медиальной прямой мышцы глаза между ними. Также это имеет значение, например, в хирургии менингоэнцефалоцели переднего основания, в данном случае травматические менингоэнцефалоцели. Мы видим с левой стороны переднюю решетчатую артерию и с правой стороны. И заранее можно спланировать, что при пластике ликварной фистулы в этой области мы можем столкнуться с этой артерией. И вот таким образом это выглядит во время операции. Другой случай – хирургия лобной пазухи. Также передняя решетчатая артерия может быть легко ранена в этом месте. Дальше наша следующая дверь, третья ламелла, это основная пластинка средней носовой раковины. На сагитальных снимках средняя раковина, вот ее основная пластинка, которая ведет нас в полость задней решетчатой клетки. Вообще решетчатые клетки делятся на передние и задние, и граница между ними является основная пластинка средней носовой раковины. То, что встречается в отечественной литературе средние решетчатые клетки, их не существует в современной классификации. Вот мы видим после удаления также продолжение той же самой диссекции. Удалена полностью, вот здесь располагалась решетчатая була. Мы видим внутреннюю поверхность средней носовой раковины, видим глазничную стенку, нашу лобную пазуху, переднюю решетчатую артерию. И вот мы видим основную пластинку средней носовой раковины. Перефорируя которую, наиболее безопасно это делать медиально и к низу, мы попадаем в заднюю решетку. Вот мы видим полость задней решетчатой клетки. Никаких средних решеток не существует. Интересным анатомическим вариантом, о котором также нужно узнать на стадии предоперационного планирования, это наличие, как уже говорил профессор Шредер, клетки анодия. Клетка анодия – это наиболее задняя, это задняя решетчатая клетка, на латеральной стенке которой располагается канал зрительного нерва. Так описал ее в оригинале Адольфо Аноди. Она часто располагается над и латерально от клиновидной пазухи. Кверху и латерально. Та же самая левая сторона. Мы в полости задней решетки, и мы видим канал зрительного нерва. Зная о том, что это задняя решетка, мы понимаем, что наша клиновидная пазуха будет находиться медиально и к низу. Опять же, в отечественной литературе часто встречается определение, что клиновидная пазуха располагается сзади от решетчатых клеток. Это не так, потому что если бы мы здесь пошли дальше кзади, мы могли бы ранить или зрительный нерв, или сонную артерию. Как мы видим при вскрытии клиновидной пазухи медиально к низу, мы видим сразу же сифон внутренней сонной артерии. И также мы видим перегородку костную, которая как раз и ведет к внутренней сонной артерии. Как уже говорил профессор Шредер, мы не будем на этом подробно останавливаться, очень часто перемычки внутри клиновидной пазухи указывают нам на положение сонной артерии. Это также необходимо выяснить на стадии предоперационного планирования. Другой пример анатомический, когда костная перемычка подходит прямо к сифону, здесь он намеренно скрыт. Для демонстрации это случай из лор практики, когда мукоцелия клиновидной пазухи разрушила костные стенки клиновидной пазухи. Мы можем хорошо увидеть анатомию.
Having some audio problems. Marco, can you hear? Can you hear me, Marco?
Yes.
Okay, I guess
but
we're having audio problems here. I better write Anna.
yeah, maybe.
Muy buen fotos, huh?
Sí,
Sí, excelente foto.
sí, excelente.
Well, no importa el sonido porque no puede entender Rusia.
Yeah, but besides that, the picture says a lot.
Sí. Hey, hola, Patty. ¿Puede oírme, Patty?
Hola, profesor, ¿cómo están?
Bien,
Buenas,
¿tú? Buenas noches.
bien, contenta con el congreso, muy lindas las charlas, muy lindas las presentaciones, increíble.
Sí, poquito problemas ahora con sonido. Está hablando en Rusia, no entiendo Rusia. ¿Tú entiendes Rusia? No. Inglés es bastante, pero Rusia no.
Rusia no, ahí parece que vuelve.
Sí, la última profesor es muy buena, Henry Schroeder, es un neurocirujano de Alemania. Es famoso este hombre, Henry Schroeder.
Escuché mucho de él, man, pero no lo conozco.
Okay. Yo escribe los administradores para arreglar sonido, pero yo no sé.
And the front branch could be easily found in identifying the vertical plane and the so-called crista epimodalis, and it also shows us the artery. So the number of branches can vary, but you can identify and coagulate all of them. So further on, in further identification of this bone plane, you see the two processes: orbital process and clinoid process. And so we go to the lateral ethmoid sinus. So this is the opening and some branches of the artery. So the anatomy could be looked upon as the crab legs, and here we see the pterygopalatine fossa and the capsule. The coagulation of the juncture of the vessels allows to move this laterally, and the so pterygopalatine to go laterally. And another demonstration, the clinoid sinus and the septal branch of the artery, and which feeds the nasal flap for the reconstruction of the skull, is the arteries, and this is the great palatine nerve in the canal, which opens into the mouth cavity, and the pterygopalatine fossa anesthesia is performed sometimes. So canalis palatovaginalis is important in the Russian language. It's called as a pharyngeus canal. This is the canal which goes. We see the sagittal canals, what Professor Schroeder talked about, and median from the video canal. This canalis palatovaginalis with the same name nerve. So this is the left side, the opening of the video channel, and closer to the branch of palatovaginalis. So the these relations of bony openings and canals. We have to assess the CT scans if we want to go laterally and extend our approach into the video canal V2, and this is the video canal palatovaginalis. So it could look like that, it could look like that, so with good pneumatization in the lateral sinus. So we see more distance between the two nerve structures, so thus this allows us better planning. So this is the demonstration. So the crossing of the arteries, the video opening, this is canal V2. It could vary greatly from 2 to 8 millimeters. And here this is the celotochica and the paraclival carotid artery. And the video canal always leads to paraclival foramen velocellum, and video canal shows the opening because it's been formed of the great petrosal nerve, and it comes out of this cartilage of the opening. So if you want to extend our approach laterally, we have to remove the posterior wall of the upper jaw sinus and see the artery. We will not go into detail here, but towards the anatomy, this is the. So we remove the wall, and the first thing we see is the artery. We sometimes see the bulging of the artery. The artery it looks like a loop and gives some branches. So the PCA, CPA, DPA, and sometimes the video artery. And lateral branches are infraorbital, which goes parallel to V2, and another which is not shown here, and sometimes the temporal branch to the temporal muscles. So another medial branches, PCA, CPA, DPA, and so this is the loop infraorbital complex and the deep temporal muscles artery. And here we have a second approach through the mouth, and we show the loop of the and the deep temporalis muscle relation. And then the lateral is the ramus mandibulus. So if we look down with the angular optics, we see the maxillary artery, and it goes onto the temporal muscle and between the pterygoid muscle. So we all have to keep this in mind if you have seen such neoplasms. So even from a small infraorbital artery, there could be extensive bleeding, which is very difficult to cover, even with the bipolar coagulation. So we see how it's difficult to calculate the artery, so it's as intensive as a carotid artery bleeding, but it somehow turned out very well in this case. So you also have to know this anatomy when we plan the lateral approach to meninges of Celia through the Sternberg canal. And we see a V2, this is V2, this is the video of V2, and the lateral, we see the defect through which through the fornix, so the prolonged meningocephaly and the liquoria is bothering the patient. So that's the left side. We open the posterior wall of the superior jaw artery. You can cut them, and we go into the clinoid sinus, and we see meningocephaly, and we can cut it. And it's better to have a better imaging. This is channel V2. This is the defect which could be covered through plastic. And when removing this chondrosarcoma, this patient came to us from different climates. So this was the video. We see very dark optics as the surgeon removes something. Some tumor gets the bleeding, because of which he cannot continue with the operation, so he had to tamponade. And we see the fountain of blood, and so the decision was taken to reoperate the patient. And the last thing I want to show is just to summarize the lateral approaches. And here we see a good view of internal carotid artery. And so this is the left side, and so this is perpendicular plate of the clinoid sinus, VDF nerve, and palata vaginalis, we'll see it. Clinoid sinus. So we remove the posterior wall. This is Carison. So we see the downgoing of the palatine nerve bunch and the Eustachian tube. So VDF nerve is crossed. So we identified the lateral surface of the pterygal processes, and we can remove the so we see the V2 and V3. V2, V3, this is the floor of the middle cranial fossa. So this approach in the surgery of epilepsy is being developed. So the approach to the floor of the middle cranial fossa. So this is a pneumatization, and V2 here. This is the Meckel's cavity projection. So we remove all this flap with the Eustachian tube. So you have to remember that the Eustachian tube is attached to the opening. So you have to be very careful not to cut the carotid artery. So this is the removal of the cartilaginous part. And soon we'll get a good view of this is paraclavial carotid for anterior perisectomy, and so the second tube is removed, and there are nasopharyngeal V3 and VC. Parapharyngeal carotid artery, V3. So this is the cavity of inner ear, incus of the ear, and this is the final view. So we see the cavernous carotid, paraclavial carotid, petrosal and parapharyngeal carotid. So this is the fat and V2, V3, and the projection of V1 and gastric ganglia, and the cavernous sinus is here. So you have to keep in mind the position of the carotid and its possible variations. So thank you very much for your attention. If you have any questions, I don't know, wishes, or we could ask, thanks Dr. Paula for a nice presentation. So in principle, to extend your horizon and go in further laterally, many pictures for neurosurgeons are not clear, but we understand the friendship of ENT and neurosurgeons. And the pituitary surgery, it's important, and the practical course, probably you'll have to work through these approaches, but now the floor is given to Professor Sofiano. So it's not so much the anatomy as much as the technology and the tools and the form of the operation, maybe including some video films.
This is small lecture about some equipment and some possibility visualization and training of endonasal approach. Yeah, I understand that all people are very experienced, but we are a little bit sure about our possibilities in our center. Just before the dissection, just refresh your knowledge, man. Yeah. Some words about our center, because a lot of people come from not only from Tyumen region, but from Moscow. Mainly participant is from Moscow and from St. Petersburg in this time. It's really unusual for us, but I think it's so why for this in this year we celebrate 5 years of working of our center, and since this 5 years, during this 5 years, we made more than 16,000 cases. 16,000 cases from more than 80 regions of the Russia and from 12 foreign countries. It's really big achievements for us. The main principle is minimal invasive neurosurgery and save the quality of the life of the patients. Our center have very well equipped, not only for endonasal surgery, but also for all kinds of neurosurgery. We have now 7 modern operation rooms, including the intraoperative CT, angiography, all kinds of microscope drills, and so on, navigation system, so on, and also new hybrid CT operation room. Some equipment. The main equipment is the endoscopic tower. And we use mainly Storz system because the quality of image is one of the highest now in the world and in HD. And this is very important, how say Professor Schroeder, for distinguish difference color between normal tissue, pituitary gland tissue, and tumor tissue. But in recent time, we also by 3D station also, and I think the development of this kind of techniques maybe will be the future, near future in neuroendoscopy. So we have also experience not only with 2D, also with 3D, but now because the quality of the picture of commercial example of the 3D power is not so good like in 2D of Storz, for example. So why we combine sometimes in our operations 3D with 2D. This is special 3D endoscopes, 0 and 30 degrees, and this is a camera. And this is a standard set for the transnasal approach. This is endoscopes with different view of degree, 0, 30, 45, 70, and so on. This is some kind of curettes, because it's very important sometimes to remove remnants in difficult parts. And also we use a punch like a Kerrison punch, and very important the hemostasis in this kind of surgery. So why we try to use a lot of some special device for the hemostasis, like a coagulation forceps with different angles. And we have also and use some new devices, a special coagulation forceps. You see with different lengths and angle, also for coagulate some cavernous sinus point of bleeding, for example, and others, artery, for example. And also a lot of, you must have a lot of some forceps from ENT kits, and very important, this is also very interesting coagulation, suction coagulation device, very useful if you have bleeding. For example, from sphenopalatine artery, for example, and also very important some cuffed suction tube. This is some small economic variant of the kit. Also very important, sometimes very useful. This is shavers. You must have all kinds of shavers, curved, diamond, and cutting edge, because sometimes, especially if extended approach, lateral extended approach, for safe surgery, it's necessary. It's necessary. Also, we use drills with cutting or diamond bores. Sometimes not, especially on our first steps, we use a neuronavigation system. Also in our center we have any kind of system, mainly we use a curve navigation system from BrainLab. For my opinion, the interface is more useful for the surgery, for the surgeon. But main important, I think, is to estimate, as Professor Schroeder said us, estimate the anatomy on the CT scans before surgery, for understanding what's inside. So this is, I think, my opinion, is main important for understand. You must not believe only for navigation system, because sometimes it's possible mistake. Mistake is disaster. Just only combine planning before and navigation system is the best way. This is some example of our navigation system. It's possible to see some anatomical landmarks. And, but a very useful navigation system is when we operate the patients after second, third operation, where anatomy is destroyed. Also, in our Federal Center of Neurosurgery, now we try to use and for receive knowledge about possibility of these methods is the CT operation rooms. You see, the very modern, just last year, this operation room started in our center. The high resolution CT, 32 slice, work in operation room. And you see moved by rails, you see rails on the floor of the operation rooms. In any time of the operation, it's possible to check situation inside of the operation field. And another very important of these operation rooms is automatic registration. You see, automatic registration and connection in automatic regime, CT Toshiba with the navigation system. With the navigation system, and if necessary, with the endoscope sheets also. This is very intellectual system. So you register it only once before operation. So it's very easy and very quickly to operate now. Not necessary to register the instrument every time. So save your time and save your mistakes also, because only one registration time. And also, this CT give us possibility to do some CT angiography, CT perfusion during the operation. Sometimes it will be very important, especially if you have some problem during surgery. Yeah, you must check, for example, you stop bleeding, compress internal artery, and it's rare, but sometimes it's necessary. Yeah. What's happened with the brain, and again about the remnants, also very useful. And this CT is very big bore, so it's very easy, not compared to Siemens, and it's very easy to use because it's a very wide bore, and very useful, for example, for the surgeon. What we do, what we do with anesthesia support. Sorry, a little bit. Что-то не крутит у нас. Да, сам проблема. Что-то прям парни проблема. Okay, in anesthesiologists, no, so specific. So I think maybe we moved another. So some problem with computer, I don't know what happened. In our center, we practically, especially if we have large tumors, we use external lumbar drainage. Ну что это не то, парни. Ну, попробуем сюда. Перезагрузить.
Looks like we're losing the sound again. Oh, it's coming back.
Okay, some moments.
Maybe the video doesn't work.
Okay, está arreglado, dijo.
Подожди, что-то у меня перевелось. Watch video, I think. Вообще не загрузить надо. немножко компьютер сюда. Да, перестань. На дренаж сразу. Okay, thank you very much. Yeah. So in every case, especially in large tumor, we do lumbar drainage. Because if Louis lumbar drainage, it's very easy to manage with the capsule, capsule of the tumor. The technique is standard. Tohi, put inside of the Tohi needle the catheter. In some small case we don't use, but in big one we use. Patient position is also very important. Why? Because it's possible to also management of the membrane and also management of the venous pressure. It's very important for the stop bleeding, for example, management of the bleeding from the cavernous sinus. This is our technique. Because we use hybrid operation room, so why you understand this is special device for the holding, the head is a carbon, the CT negative carbon. And special fixation of the head also, because sometimes if you have difficult situation with the disaster bleeding, for example, you must practically vertically sit in position to prepare for the patient to stop bleeding. Easy management. And also you see how we start prepare the special holding device. We use special Mitaka. This is pneuma holding device. From Storz also, very useful. But it's very important to check the measurements for very useful length between the holding device and the nose. For the maneuverability, for the freedom of the endoscope. You see now, check, possible, not possible to operate, easy. And you see how we up, down the patients. This exercise gives us a possibility to manage by the bleeding. And this is prepared for the nose cavity. This is standard, like in ENT. We don't use needle injection by the needle. Not used by the gauze. Slightly turned. If you are right hand neurosurgeon, and check the holder. It's very important. Maneuverability of the holder. This is nurse working is also very important. So why we show some videos about how nurses prepare for this kind of operation, and to see what instruments you must have on the table of the nurse. In our center. Photos. Operation room supplies, what we have inside. Also, 2D store system is a very important tool with high resolution. and in hybrid operation room. Second, we have also 3D. And it is very easily switch between 2D or 3D. Mainly we use this kind of switching on our first steps, because 3D image is a little bit different from the 2D, and it needs some experience for working. But the angle of the view of the 3D is very, very good. So it's even zero give very angled view. It's very useful. Also, we use navigation system prepare. And no X-ray now. How we disinfected our operation fields. We made more than 300-400 operations now. No meningitis connected with kind of sanitization operation field. Special surgical towel. Ну, полотенце или белье, я не знаю, как. This always is a single use, more preferable. Always very important if you start. Not for experienced surgeon, but for starting, it's very important. Especially for the instruments, it's possible to use the pockets, like in pockets. And connect the cables, a lot of cables. Surgery. Surgery is a standard technique, 2 nostrils, 4 hands technique. We show you some small video about the 3D, how it's do. You do with glass. You see the monitor. And in this kind of surgery, it's possible to do it's possible 4-hand technique, but this is 1 surgeon, but it's possible 2 surgeons for hand. No problem. Usually 1 surgeon take the suction. And after operation, or maybe during operation, if you have some question, what's happened, maybe you mind about complication, maybe, or maybe mind about you remove completely, or maybe have some remnants. In our operation room, it's possible to check this condition by CT during operation. Very fast. Only cover by sterile and make CT. This is CT. You see how it's gantry. goes. And this is quality of picture. You see how it's high qualities. Compare the MRI, no problem. Possible to see remnants, complications. Radicality. The quality of picture is compared like a MRI in this kind of CT. And also possible to do some 3D model and to see check your body effects, how you make it. And this is the last step of our surgical procedures usually. If all is okay, no remnants, no bleeding, we finished. This is our standard equipment of our, again, surgery. Thank you very much.
Спасибо Альберту Акрамовичу за.
Thank you, Albert Akramovich, for the presentation. Are there any questions? Or you can prepare questions in writing, and by the end of the day, we will accumulate all the questions, and at the end of the day, we'll have a discussion and discuss. Of course, it would be, I can't even imagine, difficult to imagine what will happen with neurosurgery in 10 to 15 years, because even 5 years ago, imagining the equipment, the study methods, pre-op and in-op, and taking into account the experience gained in the labs and thorough study of microanatomy, well, it's probably that endonasal surgery has promising outlook. And in this presentation, what has been mentioned is probably a disputable thing about the use of 3D technologies in neurosurgery, not only in transnasal surgery. Maybe it's the quality of image, or maybe it's orientation difficulty because of the depth of perception of the processes and the volume of perception of anatomic landmarks. But I guess without experience, without using different technical techniques, well, there will be no progress. So you need to understand this through practice. So this technology, by all means, needs to be studied and developed. Moreover, this 3D technology, it's just pressing through a push of one button, you can switch to 2D. So thank you. And as a continuation, the next presentation. Are there any questions? Professor.
Okay, very good. I believe there's another presentation.
Will be the future, but nowadays I'm not convinced that the systems are really ready for the market. I know the Vision Sense system, and we have tested it, and the color fidelity, if you compare to the standard 2D camera, is less. So the color fidelity is not good. It's unnatural colors. And then I asked them, everything looks so red, and then they turn the button, everything looks green. And then I say, no, it's too much green. And then you know, it's a virtual image, and I'm not convinced. I don't use it. And there are developments. I have seen a new system from Karl Storz. A 3D endoscope is much better with the color fidelity. And if they improve it more, I think this will be a good tool to use. But nowadays, I'm used to have a 2D image. When I use the 3D image, for me, it looks very strange because you have an overestimation of the depths. So everything looks very deep. But if you're used to have it and you are used to use it, many people are happy, even with the Vision Sense, which I do not understand because the quality of the image is really poor, in my opinion. Although they have improved in the last years. But I think in the future, of course, it will become better and better. We will have 4K cameras, and then we will also have a better 3D visualization. Many people don't like also the glasses. Some people feel dizzy. When you move your head, you see the image is moving in a strange way. So many people don't like it. And we have our general surgeons, they purchase a 3D system, they make a big marketing campaign, and now if you go to them, they always use a 2D system. So I think it's not convincing, but I think it is the right way to go in the future because we used to have 3D view. That's why we frequently use endoscope-assisted microsurgery. So we do a lot part of surgery under the microscope because I have the 3D visualization, perfect illumination, and then we use the endoscope just for certain steps of the surgery because microscope with 3D visualization, good optical resolution is of course preferable. But nowadays I would stay with 2D.
Okay, tomorrow I show 3D and all participants choose your opinion, okay? 3D or 2D, no problem, tomorrow.
As a continuation of the morning session and taking into account the fact that we've listened to the lectures about approaches from neurosurgeon and the ENT doctor, we have seen a wonderful presentation, illustrated anatomy of this region, but let's not forget that practicing the skills and having wonderful opportunities for surgical removal of various difficult anatomical processes without trauma injuring, avoiding injuring of large vessels or neuroformations. We remember that there's a possibility for the cerebrospinal fluid to flow out, and the variations of plasty and completion of surgery are as critical. And Professor Schroeder will give a lecture on closure of surgical defects after the end of surgery.
It looks like Dr. Schroeder is getting ready for another talk.
Yeah.
I believe he's going to talk about skull-base reconstruction techniques after endoscopy.
A short presentation just to show you the technique which we use for the skull-base reconstruction. You know, it's very important that you have a reliable closure of the skull base, especially if you make extended approaches. And there are publications of a lot of techniques which can be used. So we try to make it very simple and depending from the degree of CSF leakage we have. When we expect a lesion, you see this is a chordoma patient, and we look here, you see there seems to be a dura covering the whole lesion. So this looks to us to be an extradural tumor. When we see this, we don't raise the nasal septal flap. Some people use a nasal septal flap in all surgeries, even small pituitary cases, because they say, it's very reliable, I have a low CSF rate. It's probably true. But the harvesting of the flap itself may cause trouble for the nose, discharge, crusting, and this may last for a long time. So if it's not required, we don't use it. So we look to the MRI, we make a judgment, what is the CSF leakage? Is it high risk, low risk? It's a high flow leakage, it's a low flow leakage. So from these factors, we choose our reconstruction. And we think about it before we start with the surgery, because if you need a flap and you don't raise it in the beginning, you make a standard opening for the sphenoid sinus and you will destroy the pedicle, and you cannot have a pedicle flap. For example, in this case, you see this is a chordoma, obviously, rising here from the clivus, and you see this is a purely intradural lesion. Then we know, yes, for this we need a flap, so we harvest a flap. So our policy is, if we have no CSF flow during the surgery and we do not expect it before, we just put gel foam. If it's a microadenoma, sometimes this is all we do. We don't close the cellar floor. Frequently, we use an artificial PDS folia. This is a folia. It is used for orbital roof reconstruction by the maxillofacial surgeons. And we use it to close the cellar floor. Sometimes we use bone, but this is rare. If we have during a pituitary surgery a minor CSF flow, we take a little bit fat from the periumbilicus area, and we glue it with fibrin glue, and we take the PDS piece to reconstruct the bony floor. Sometimes we use simply collagen. So, but I think if you take fat, you're on the safe side. But sometimes we are lazy to take the fat, and then we take a little bit of collagen, which might also be okay. If you have a major CSF flow, usually we want to have a nasoseptal flap. If we have a high flow leakage, that means we have opened the third ventricle. In craniopharyngioma cases, we use fat, fibrin glue, flap, lumbar drain for 5 days, and we pack the nose. If we have a standard pituitary, usually we don't pack the nose, and the patient can breathe freely after the surgery. Some people are concerned about lumbar drain, and that is certainly correct. If you have a patient which is not compliant, it's dangerous to use a nasoseptal flap. We, for example, had the experience with one lady. We make a reconstruction of the frontal skull base, and this was after resection of an olfactory groove meningioma. It was a recurrent case where the tumor grew into the nose. So there was no cortical cuff over the skull base, but was a big cavity filled with CSF. So we placed everything, and we put the lumbar drain. Patient stands up, and all the reconstruction was falling into the cavity of the skull. And then she developed brain abscess. So if you have a lumbar drain, you must really take care that it's really handled properly. That means the upper limit of the lumbar drain is always in the level of the external auditory canal. So if the patient stands up, he has to elevate it to this level. If he's laying down, you can bring it down again. So just some examples. This is a microadenoma. So you see we open the bony floor in a rectangular fashion, and this distance is longer than the vertical. So the horizontal dimension of this bone, which is raised, is longer than the vertical one. Then we take the whole stellar floor as a single piece. It's a small 1 millimeter kerrison. And you have the stellar exposed. That was a microadenoma here. So we remove the microadenoma, and then to reconstruct the bony floor, we simply bring the bone in and we turn it 90 degrees. So the long axis of this flap is now the vertical axis. And then you have a kind of reconstruction of the bony floor. Many people say it's not necessary. Certainly true. We not always do it. Sometimes we just cover it with gel foam, but it can be done if you want. This is a resorbable plate. It's made of PDS. You see it was a pituitary adenoma. We put some gel foam in the cavity, and then we use this polydeoxanone piece. We bring it epidurally. So we try to put it on the dura epidurally, and this keeps our fat or our gel foam inside, and it's not falling out. This is quite useful. This is a technique we use quite frequently. Fat can be used. You see, this was a chordoma case, and we had not a nasoseptal flap. This is a big defect, and you know it's a high risk. So we put one piece of fat into this clavicle defect, and a second one, which is not completely filling the sinus, but it's filling the sinus. You see, this was a chordoma case. And then we put a lumbar drain. And in this patient, we had no problem with CSF leakage, but it can happen. So it's better in these cases you raise the flap. Nasoseptal flap is a good idea. It's not so new. I saw a paper from Hirsch. It was in the 1950s. He also raised a flap from the nasal septum, but nobody was recognizing it. And then there was a publication of Haddad and his co-worker in 2006, and they described this big flap where you can take the mucosa from the nasal septum. If you go here, you should keep in mind that the septum, the medial septum, is very important for olfaction. So you should always leave at least 1 centimeter of the mucosa in this area where you have the olfactory fibers intact. Otherwise, it's a high risk that you lose olfaction. Another structure which is important for olfaction is the superinterminates. Also, these should be preserved if possible. If you take the septum away from here, all this part is denuded from mucosa. So what happens? Crusting. The amount of crusting depends from the amount of bone you leave behind without coverage of mucosa. That's why when we make a standard pituitary case, we just remove the mucosa and the sphenoid sinus from the cellar floor. So we don't pull everything out. Only when you have the flap, then you have to remove all the mucosa. Otherwise, you will create a mucocele if you put the flap on the mucosa. But if you have this septum without any mucosa, it takes at least 4 months. There's a publication showing it takes 3 months, in our experience, at least 4 months. And we had one patient, he suffered even after 6 months from crusting discharge. So it takes a long time. That's why Rick Harrow had a good idea to make a reverse flap. So it means on the other side of the septum, you cut the mucosa in the opposite way. Then you remove the bony part of the septum. So half of the septum is removed. And then you flip the mucosa to the side where you took the flap. So you see, we flip the mucosa on the other side. Then we suture the mucosa to the cutting edge where we took the flap. And then you have the septum, most of the part is covered with mucosa. And then the revitalization is much, much faster. And the discomfort of the patient is really less. You will see this if you try this, they do much better. It's really a nice idea. So one example here. We have a clival defect. See, this is cellar, carotid. So you have a big defect. To fill this defect, the best is you use fat. We take fibrin glue, fix it here, and then on this, we use the nasoseptal flap. It's very important that all septi, which might be here, are drilled flat. That the flat has really a good plane to put it on. You see this in nasoseptal flap. It should be always in contact. There should not be air in between the flap and the bone. If you have a very deep indentation of the clivus, we take more fat, that the flap has a plane to lay on. So it's very bad if it's not in contact. So the flap should be in contact to bone. And we avoid any foreign material. Many people, they use some Duragene or Surgicel. They put other things in between the flap and the skull base. We never do this because then I have not a vital tissue. And in my opinion, the flap cannot heal as well. So it should really, the flap should lay on the bone. No artificial material in between. You see, this is the post-op MRI. If you see this image with a very good enhancement of the flaps, then you know it's a good perfusion and you should have a good healing. And this is a fat suppression MRI. That's why the fat which we placed here is dark. So we usually take a monopolar electrode. We cut here along the choana. Then we go down to the floor of the nasal cavity. We go more in front. And then the length of the flap depends from your defect. So usually you go close to the mucocutaneous junction. You expose the cartilage. It's very important that you do not go through. So make no hole in the beginning. Then the ENT doctor will shout you, because this is not for the nasal, not good for the nasal anatomy. You see, here we leave at least 1 centimeter from the skull base. And then we raise the flap. Sometimes you have some bony spurs and the flap becomes very small. This can happen. And then we cut here along the choana so that we have a good possibility to bring the flap in the position where we want to. So the nasoseptal flap is very good. So this is a case where we had a Radke's cleftus. So there was not much CSF leakage, was no opening of the third ventricular floor. So we did not use fat, we just put gel foam in the dural defect. And then we took the flap, positioned it on the skull base, and then we glue it. Take fibrin glue. Then usually we put some Surgicel on it, and then gel foam, and then we take tamponades. 1, 2, 3 on each side. So the patient with a craniopharyngioma, you see, is a big hole. These are the patients with the highest risk of problems, so we use fat. It's very important that you take care that the fat is not falling down into the third ventricle. That would be a disaster. So the major part of the fat remains outside. We take fibrin glue, and then you see the flap again is put on the skull base. Very important that you have no folding here, that really it is flat on the skull base. We take fibrin glue, then we put Surgicel on it, then we put gel foam. Gel foam is only to prevent that your flap is sticky to the tamponades. If you have for 5 days a tamponade and you remove it and it's sticky, it may come with a tamponade. That's why we put gel foam, and then you can easily remove the tamponades. So some people say with a nasoseptic flap you can decrease the CSF leakage to under 5%. Maybe it's a little bit over optimistic, but I think it's really a good technique to prevent post-operative CSF leaks. We had 2 patients with craniopharyngioma. They presented with hydrocephalus. And these patients continue to have leakage, although we had a nice flap. And finally, they ended up with a shunt, a VP shunt, because the pressure was too high. And then after 1 year, we removed the shunt from the patient, and it was fine. Any questions? Вопросы есть?
If we can inflammatory complications, what time and what kind of construction we use?
You mean if you have meningitis?
Если у больных имеется политраума, то какие варианты реконструкции?
Your tactic in case of inflammatory disturbances.
So I don't remember that we had to make a special reconstruction because we had an infection. So we make our instruction, and then if the patient would get meningitis, we just treat with antibiotics, but we would not change the reconstruction. This is only in cases when we have a spontaneous CSF leakage, patient comes in with meningitis, then we close the defect, and then we usually take only autologous materials. That means fat, sometimes a flap, a local flap, middle turbinate flap, or if you have the big defect, we take fascia lata. But we try to avoid to take fascia lata. We don't use it much. More the ENT doctors, they use it more frequently than me because this is causing pain, and I think it's not frequently necessary if you have the possibility to make a nasoseptal flap. But no special reconstruction in infection. So if you have a post-operative infection, and I had already my reconstruction, I just treated with antibiotics, so I would not change it again, only if it's not sufficient. If you have a defect and you see CSF is coming, of course you have, for example, you have to take another piece of fat to glue it there and keep it. Is this your question, yeah?
What time reconstruction and тяжесть выраженных воспалительных реакций.
And the severity of the inflammation complications. What's the time? Depending on the acuity of inflammation or degree of inflammation of the liquor area. So does the time tell on the tactics that you use? The time to close the CSF leakage.
Ask again.
Имеет ли значение?
Is it important the acuity of inflammation reactions when you have a CSF leakage in, and does it tell on the time of the reconstruction, on the duration of the reconstruction? The severity of the inflammation, does it tell on the time of repeated reconstruction operations?
We have very rare problems with infection. It's a very low rate. We had one patient with a brain abscess after we made a transcribiform approach, what I told you, because everything fall into the brain. And then, of course, when we saw on the postal MRI that our reconstruction was gone, we repeated it, we removed it, and we put another layer of fat and glue immediately, because we saw that the reconstruction is not in place. If you have an infection and meningitis, but your post-op MRI shows that the nasal flap is in good position, then you just take a CSF from the lumbar drain to check what bacteria are inside, and then we make our antibiotic treatment according to the resistogram. So if you have problems and you see the construction is not okay, it doesn't matter whether there's inflammation or not. If you see CSF is coming, immediately you have to treat it to prevent infection. But the rate of infection is really very low. Even if you open up and make an extended approach and open the dura, it's very low rate of infection. And we give only once antibiotic prophylaxis. With induction of anesthesia, we usually give cefuroxime, single shot antibiotic prophylaxis. If we have tamponades on both sides, then we give for that time antibiotics, because then you have a stasis of the mucus, nothing can come out. This we do. But in the normal cases, pituitary cases, single shot. No, we fix it. No fat, no fat, no. No. We make a snowball and a snowman fat. So a small piece is inside the defect and a bigger piece stays outside the skull base, so it cannot fall. Then we fix it with glue. No. And if you see, initially is a big piece of fat, and after 3 months you make an MRI, you see it shrinks down. Sometimes we fill the sphenoid sinus just with fat. We do not cover it. And after 3 months, almost all fat is gone. The problem with the fat, the only problem, in my opinion, is that some patients, they have really a problem because of the bad smell. There's a decay of the fat. And exactly, yes. Exactly. That's why we tried to put this plate on. But we had cases, formerly we just put fat, and then some patients have no problem, but some patients have a very bad smell, and especially the partner is complaining. Because, no, don't come too close to me, because of the bad smell. That is the problem with the fat, but if this fat is going in the CSF, I think it's no problem. So I think now we are ready with the lectures and want to go to the laboratory. But first I want to show you a video showing our approach with a pituitary gland. And this is the first step, what we want to do in the cadaver workshop. And that's why before we start, I think I show you the video that you understand what we want to do. And this is what we do then in the cadaver lab. It's a standard approach to the pituitary gland. This looks strange. One moment. It was not warm. So this is our technique, how we do it. So first, you make an inspection. We have a suction irrigation device, what we use first. You go into the nose. This is the right nostril. You see the septum. You see the choana, the lower turbinate, middle turbinate. Then we go to the other side. See, septum, lower turbinate, middle turbinate, choana. These are the main landmarks which we should identify before we do anything. So then we have patties soaked in with epinephrine 1/1000. And these are placed in between the septum and the turbinates to get some space. You see, this is a dissector. So we lateralize the middle turbinate. It's very important to get space. So you push the inferior turbinate to the side, you push the middle turbinate to the side, you push the superior turbinate to the side. Then we do it on the other side as well. You go in, lateralization of the inferior turbinate of the middle turbinate. Sometimes the inferior turbinate is very, very strong and we have to fracture it. Then we identify here, this is superior turbinate, this is the septum, this is sphenoethmoid recess. So you have to push the superior turbinate a little bit laterally. And then usually you see the ostium. Not in all cases, but frequently. And the distance from the choana to the ostium is about 1.5 centimeters. It can be a little bit more, a little bit less. This is a monopolar suction. You see the tip has monopolar electrode, so you can coagulate it. This is the area where the supply comes from the flap. So if you want to raise a flap, you cannot do it. But if you make a standard pituitary case, we just coagulate the mucosa in this area and in the posterior part of the septum. You see the ostium is now widely open. So we go to the other side, the same thing, identification of the sphenoid ostium. This is superior turbinate here. And we coagulate mucosa in front of the anterior wall of the sphenoid sinus, and that's the posterior part of the septum. Then you can fracture. Nowadays we fracture first the septum, but you can also take simply a drill and you start to drill. You need irrigation for that to keep the lens clean. And then you expose the rostrum. You see this is the rostrum of the sphenoid sinus. If you see that, you know it's the right way to go. But you see the posterior septum is in my way. It's always disturbing me. And that's why this posterior part of the septum has to be removed. So we can take a kerosene, remove septum to get better access. And this amount of removal depends, of course, where you want to go. This is a backbiter. It's a very nice instrument to take the posterior part of the septum away. See, you insert it on the contralateral side, and then you see this biting. Then we open the sinus more, and here is an artery which is in very close to us. This is a posterior. You see here the posterior branches. So there's a septum branch of the sphenopalatine artery, and this must be coagulated very well. We had some patients, they came after 10 days with massive nasal hemorrhage, probably from these arteries. So you have to coagulate it very, very precisely. Then we have to open the anterior wall more upwards to get access to the upper part. But we should avoid taking the superior turbinates. And then you see now the anatomy, left optic nerve, lateral OCR, carotid. This is a bulging of the stellar floor because of the tumor pressure. And you see the septum here. So it's optic nerve left. This is the clival carotid, cavernous carotid, goes down. And here you see the clivus, so clival carotid. Other side, optic nerve, lateral OCR, clinoidal carotid, cavernous carotid, and the clival carotid. And then, as I told you, the crossing depends from the amount of bone which is exposed to air. So we just take the mucosa here on the stellar floor. We don't strip the mucosa from the whole sphenoid sinus. Very important that you have a good outcome in terms of nasal quality. So we just remove the mucosa from the stellar floor. And you see we make a forehand technique, so we have not a holding device holding the scope, but an assistant is holding it, and so we have a dynamic endoscopic visualization. So we remove the septum, and then we use a high-speed drill to open the cellar. So this is the step what I want you to do in the lab now. It's a standard approach to the cellar area. You see the bone is very thin in tumor cases frequently because of the chronic pressure. Then we remove the bone. to expose the sella. Small forceps. Take all the bone part out, makes the nasopharynx clean, that the patient does not need to cough too much. Because if you have a CSF leak and you have a reconstruction and the patient is coughing, the pressure goes very high up, and this may also endanger your reconstruction. Kerosene can be used to widen the cellar opening, and then we take a blade, a retractable blade, and then we cut the dura. So there's different ways to cut it. You can make it cruciform, you can make it round and take the whole piece out. What we do now frequently, that is not disturbing that the dura is in your way. So anyhow, we never close the dura, so you can really shrink it. See, tumor comes out. If you're lucky, you have a tumor like this. Fortunately, most of the pituitary tumors are very soft, and then it's easy to resect them. We take a lot of biopsies for histological evaluation, send some curettes. I like to have the sharp curettes. There are some people, they have only the blunt curettes, but I think with the sharp curettes, I think it's a better resection. It's very important, if you start with the resection of the tumors, you first take the lower part of the tumor. Then you go to the side, left and right, but don't take the upper part first, because then the diaphragma falls down and is always in your way of the dissection. So first you resect the tumor in the lower part, and then you go to the sides, and then the last piece is then the upper part of the tumor. I think it's very important that we have bimanual technique, not just in one hand the endoscope and the other hand suction. See, this is the dura already here coming. Here is the diaphragma coming, and this is the problem here. There is a folding between the dorsal dura and the diaphragma, and you have to elevate it, otherwise you can miss tumor in this folding behind. And you see here, this yellow thing is a normal gland. So I elevate it, and you see there's more tumor. And with the endoscope, you can really go into the cavity. You see here in this folding area, there's no tumor left. So you have a very good control, even if you only use a 0-degree endoscope. If you have tumor which goes more laterally, we use 30-degree endoscope, 45-degree endoscope. Then we take a little bit, a small patty to protect the diaphragma, and then we elevate again to get access behind the diaphragma, and we can remove more tumor here. So now we have a 30-degree endoscope. Look up. There's no remnant in between the diaphragma cella and the dorsum cellae. This is our dura, and you see the yellow thing on the diaphragma is a normal gland. Then we put some gel foam to fill the cavity, but you see the diaphragma must always try to push it out. And then we have this resorbable plate, and we place it. Usually we place it under the bone. If it's not possible, you can also place it intradurally, but if possible, we place it just epidurally. And that's it. Then important is the last step, that you again medialize the middle turbinate to keep the ostium free. This makes a sinus that you have not problem with the outflow of the mucus from the paranasal sinuses. You see again medialization of the middle turbinates, and then we don't use any package. So this is the standard procedure which we want to show you now in the lab. I think we make first coffee break, and then we go down. All right, thank you.
Спасибо за сообщение. В первой части.
So, in the first part, having watched the lectures and the videos, especially the students who are far from the pituitary surgery, you have understood that these operations are easily performed. But this alleged simplicity, because Professor Schroeder have shown us the removal of the gland at a very thin arachnoidal membrane, and the traumatization is very simple It's very easy to traumatize, and then the patient develops all sorts of complications, and then you have to prevent the leukorrhea, especially if there's a nasopharyngeal leakage after the successful discharge with good electrolytes and good urine and improvement of eye vision. The patients develop meningitis, especially in remote places, in like district hospitals, and so this remote complications has to be prevented at the surgical intervention stage. And by performing the surgery, you have to remember how you're going to leave this area and to use the important methods, and to remember that this nasal approaches you have to put into a plate of ENT doctor. You have to be scrupulously performing the approach into the bottom, the floor of the thoracic cellar, making a flap or leave the nasal cartilage for the plasty of the defect. So you have to remember that this is a conditionally sterile, because nobody can guarantee a septic end of the surgery, and that's why Professor Schroeder mentioned the antibiotics prevention, antiseptics, maybe add some more antiseptics into the irrigation solutions. And that's one of the first pleasant parts of our meeting. When the coffee break, and then we start the laboratory classes. After the laboratory, the Professor Schroeder has a very complicated microadenoma of pituitary gland with hydrocellular growth, and after lunch, this operation would be presented now with a 50 minutes break, and then the laboratory class.
Okay, I believe we have a break now. Excellent video from the transnasal approach. A good quality video, and I think Albert, Dr. Sufianov, and Dr. Schroeder, as well as the participants, are going to retire to the lab, where they're going to do a transnasal endoscopic approach to the pituitary, and we're going to re-adjourn in about 5.5 to 6 hours. Okay, very good. Okay, Patty, good video of the transnasal approach, huh? ¿Tú has visto, Patty? Buen video de, ¿cómo se dice abordaje en español? Approach.
Abordaje.
Abordaje, qué bueno. Ok, regresamos y ellos van al laboratorio para hacer disección en cadáver, yo creo, usando endoscopio para transnasal a la glándula pituitaria ahora, yo creo. Entonces regresamos en 6 horas si tú quieres venir.
Gracias, profesor, y gracias por estar y haber podido televisar esta conferencia tan linda.
Ok, cualquier persona es bienvenida mañana. Si tú tienes compañeros, otros residentes, otros médicos. Ok, Marco, gracias por venir. Thanks for coming, Marco.
Thank you so much, Doctor.
Okay, and I'll send you a link in about 6 hours, okay?
Okay.
Okay.
Buenas noches.
Bye.
Buenas noches.